Hi, thanks for joining us to talk about consent. We've run two webinars recently, and my name's Jerard Ross. I'm one of the medical legal advisors for the MDU, and a colleague of mine, Dr. Nandasoma, one of the senior medical legal advisors for the MDU, are going to talk through some of the questions that we didn't manage to get to. In these two webinars, we had over 1,000 members engaging with us, and the questions really came thick and fast. And for that reason, we were conscious that there were some things that we just didn't get on to address. We knew that it would be interesting to doctors in general, as well as to those people who attended the webinar and didn't have their question answered. Ed.
Yes, that's absolutely right. There were so many questions, we couldn't get to them all. And there were some really interesting themes that emerged that we thought we'd have to do justice to in another video. First of all, unsurprisingly, COVID continues to be a really important theme as we know that the pressures are still really high out there. And we had a lot of questions relating to the impact of COVID on the consent process.
We did. We had a number of questions asking whether that risk of acquiring COVID should be discussed. For a patient, where a patient's being admitted to hospital, for instance, for an elective procedure. And we know that some people have really strong feelings about it, feeling they were being singled out in their speciality and required to discuss that risk. What was your take on that?
Yeah, I think it's a really interesting point, and I think it's one of those other impacts of COVID in that it makes us maybe think about things in a slightly different way. For example, I thought this was similar to kind of the questions we had about doctors discussing all the side effects of drugs as part of the consent process. And I think it really reflects the fact that medical practice, even before COVID made things even more difficult, was a complicated process. Nowadays, when you're engaging a person in healthcare and therefore in a consent discussion, they're often agreeing to more than a single intervention. They're agreeing to a pathway of treatment which may involve a large multidisciplinary team, various departments and various interventions, be it a prescription, a procedure, a stay in hospital, outpatient appointments and things to make it complete. That was my first thought. I think to deal with the question more directly, I think certainly the risk of acquiring COVID in hospital would qualify as a material risk. And that term material risk obviously comes from the Montgomery judgment that we talked about in some detail in the webinar. And it's the sort of thing that you certainly have to tell patients about. Of course, you can tell them in a way that puts this in context and emphasizes the precautions that you're putting in place to stop hospital transmission. And of course, most patients are going to have to balance their concern about COVID with their need for elective treatment, and that's another aspect of the discussion that I've certainly had with patients who are having sort of elective or semi-elective procedures, with patients sometimes deciding to defer their treatment, and in other circumstances really wanting to press ahead with it. And I think that this is a kind of discussion that very many of our members working in different specialities have had to have, and it just I think reflects the times. So those were my thoughts. Jerard, what do you think about emergency admissions? Do you think that will be the same?
Well, I think the balance of risks and benefits is slightly different. And in that setting, presumably the patient has agreed the need to be conveyed to hospital urgently. And I guess that issue is less pressing. Although I know that the doctors in hospital and the staff in hospital will be discussing with the patient how they can reduce the risk of acquiring or indeed spreading coronavirus within the hospital. We've also had that expressed in a slightly different way, though, to do with consent. This was the idea in the past we may have taken clinic or a particular interaction with a patient just to get consent. And patients have become, it appears, more reluctant to come to hospital just as they see it to go through a consent process in advance because they're worried about that unnecessary exposure to COVID. What were your thoughts on that?
Yeah, I think that is an interesting point, and I know there are certainly patients I've come across that don't want to come up to hospital unless it's necessary. They're willing to come up for the treatment, but they're a bit more reluctant for any of the kind of preparatory steps. I think this is something that can be overcome, though, and I think we've got to to be careful in our analysis to separate two things. The patient signing a form is obviously important; it's evidence of their consent. It's important for checklists. But the kind of GMC guidance focuses on the issue of a meaningful dialogue, and there's nothing to stop you having that remotely or on a different day or at different appointments from the one where the patient comes up to physically sign a form if that's on the day of the procedure. So if you have detailed telephone discussions, you record that in your clinic letters, you've sent the patient information leaflets or directed them to other sources of information, given them the opportunity to ask questions and answered them, you've captured those discussions in your records. Well, the fact that they're signing the consent form on the day of the procedure itself, I think, is acceptable, providing you can evidence the fact that you've had those meaningful discussions in the run up to that.
Yeah, I think that's reasonable. I think it also applies to some of the other questions though that we had, and they're kind of moving away slightly from the COVID topic. We're talking about quite a complicated journey of exploring their concerns and sharing information with them. But some of our doctors that we work with work under a lot of time pressure. This is particularly a concern for our members working, for instance, in obstetrics and anesthetics, when they had a rapidly evolving, possibly deteriorating situation, a patient in pain and possibly in distress, perhaps at that point not being in the best position to consider complicated information, and yet needing to have something with significant risks possibly done urgently. So, what would you say about the difficulties of consent in those sorts of situations, Ed?
Yes, I mean, it's obviously a concern, as you say, to anaesthetists, doctors working in obstetrics and gynecology, but it's also an issue, I'd say, for any doctor working in an acute speciality. And the GMC guidance recognizes that consent has to be both proportionate to the decision and done in a fashion that recognizes the condition of the patient and the time constraints. And even some of the post-Montgomery case law recognizes that the amount of information you can share and convey in a pressured situation is different from, say, an outpatient setting. But again, I think this is a challenge to us to think a bit more broadly about the consent process and what we prepare patients for. So, say a patient coming up for who's having antenatal care or who'll be having an anaesthetic, if they're given some information beforehand on the things that might happen and what might need to happen quickly, that again is good evidence of having had a meaningful discussion about those issues, even if it's not exactly at the time when the issue arises, because of course you're unable to because things are moving too quickly. So I think we've also got to think about broadening our conception of when we can share information and how that whole process works as well.
Thanks for that. We've had a sort of similar question came up from some of our doctors in emergency medicine um, uh, in terms of urgency. They were asking about the situation of when a patient, um, I almost said walks in unconscious, but of course I meant is brought in unconscious, and they come in alone, and you can't get any information from anybody else. Well, what can you do in that situation?
So, of course, here, if you're dealing with an unconscious patient, it's impossible for you to seek consent from them. You also, by the sound of it, in this scenario, you've had no one who will be able to have decision making authority for someone who holds a power of attorney, say. So in that situation, you're dealing with an incapacitated patient and you have to make decisions in accordance with the Mental Capacity Act. And that act certainly authorises emergency treatment to be delivered in terms of life saving treatment to preserve life. If there are issues that you need to resolve to keep the patient alive, etc., before you work out the patient's wishes. Where there is a bit more time, where you're able to reach a best interest decision as required by the Mental Capacity Act, then you'd obviously consult with those you're able to in a different situation, if the patient comes in with a carer or a member of their family, or you're able to contact a member of the family or someone close to the patient, then you'd involve them in reaching a best interest decision. And when doing so, you're going to give them the necessary treatment and what's appropriate to their needs. And I guess there's a nuance in the Act, which is it talks about picking the least restrictive option. So gut is a slightly different concept, but it largely means picking the course of action that best preserves their options for the future. Say, for example, if you could give limited treatment now and it makes sense to revisit what other treatments are done in the future without unduly compromising their clinical care at a point maybe, say, when they've recovered capacity, then that's probably the most appropriate course of action.
Yeah.
There's nothing, certainly, just to be absolutely clear, there's nothing to stop giving emergency treatment to preserve life, even if there are issues about powers of attorney or advanced decisions in the background that you're unable to clarify in a relevant sort of timescale.
And on that point, you've talked about the Mental Capacity Act, which of course applies in England and Wales. There is similar legislation in Scotland and a similar legislation in Northern Ireland, and the approach would be, if not identical, then very similar.
I think that's absolutely right. I mean, clearly Scotland has had a Mental Capacity Act for longer than England has. The implementation from the Act in Northern Ireland has been sort of piecemeal, but the approach to patients lacking capacity is essentially the same, and it's obviously based on long-standing common law principles. So I think that we can certainly approach it in that way wherever we're practicing in the United Kingdom.
We also had a number of questions, and it is a theme that comes up again and again, particularly I think from more junior doctors, about consenting for procedures outside your speciality. An example that came up in the webinars was, I think, a general physician on call being asked to consent for an upper GI endoscopy acutely. What would you think about that?
Well, that's a question particularly close to my heart as a gastroenterologist, and it's a situation that I've personally come across in the past, and I know it leads to a lot of angst. I think it's a common theme, and I think we need to be a bit nuanced about that. The GMC guidance has, for quite a long time, since the last iteration in 2008, has been careful not to say who can or cannot consent to a procedure, but says, look, you should be properly trained to have an effective discussion with that patient. And of course, the responsibility for ensuring that appropriate consent is in place should remain with the person doing the procedure. And of course, your hospital may have restrictions in place as to who can take consent. Or the foundation school or the postgraduate deanery might say, look, this is what we think about consent, and you have to observe those restrictions. But I think we've all got to think that actually practically any doctor involved in the care of that patient can contribute something to that consent process. For example, the junior doctor might be able to explain the reason for the endoscopy, what particular problem or symptom they're investigating, the urgency of it, and why it's necessary, with the endoscopist following on with a discussion about the technical complications of the procedure and what they might expect.
Yeah, so I mean, it's the nuance, it's the journey. It's rather than just thinking about that signature at the end of the discussion on the form. The patient having to understand the procedure they're having done, the indications for it, and I think everybody would have a role in that, even the person who's not in the speciality. We've had the question expressed in a different way, though, when we've had doctors asking about assessing capacity when a treatment isn't in your speciality. And again, this is the sort of thing where even if you wouldn't be necessarily best placed in assessing exactly what information the patient would need to understand and weigh and to contribute to that decision, you might have a lot of useful information as a professional about the patient's background conditions, what their level of function is, and understanding and what their level of understanding is generally, and any help that they might have in communicating their decision. And again, whether they understand your rationale for recommending that course treatment, as opposed to those technical aspects of the procedure that you as a specialist gastroenterologist or me as a surgeon might be thinking about.
Yes, and on a similar sort of theme, we had a lot of questions about revisiting of consent. If a patient has signed a consent form, has gone through the process but doesn't have their procedure for some time, and how long, if you like, the consent is kind of valid for.
It's a question that comes up, and I remember it coming up on a number of occasions in my own work clinically. It's a sensible consideration because there isn't obviously an absolute defined time limit as to when consent becomes time expired, or there's no best before date on it, if you will. Needs to say, though, that it'll depend on a number of different factors. Some patients may have changed their mind, or it might be the condition of the patient has changed or progressed, such that the risks and benefits and the balance of them, as discussed in that first consent discussion, particularly if it was a few months before, may not quite be right now. So I think the only sensible thing to do in that situation would be to say that the longer time that's passed between that consent discussion and the intervention, the more you have to think about whether or not things have moved on. And of course, if you're dealing with a patient whose condition is subject to rapid change, this might raise this question significantly and frequently. In other circumstances, it might be just enough to confirm that the condition hasn't materially changed and that they haven't got any other questions and they still understand what they've been admitted for. I think the example that we discussed on this point in the webinar was the idea of getting consent sometime before having a vasectomy done. It's not likely to be a condition that changes. It's likely that consent done some time before is likely still to be valid, but there may be questions that need to be addressed on that day in the hospital or in the clinic.
Yeah, I think that's right. I do remember that question. And I think it was also phrased in the way of sort of saying, is it okay for the patient to sign the consent form on that day? And I think it's how these questions all sort of link together. And that I think our view on that was that it'd be quite inappropriate for a patient to decide that vasectomy as a mode of contraception was appropriate to them on a single visit on the day they were coming for surgery. But if those discussions had taken place and were documented, the patient had reached a settled discussion with an opportunity to address those questions with their GP or whoever was referring them for the treatments, then the fact that they talk about the kind of technical complications and sign the form on that day isn't particularly problematic.
Yeah.
We did have some questions that were a bit more specialty specific, but they came up often enough, and I think were interesting enough for us to try and sort of work through. One of the examples we had was the radiologist saying, look, should they be consenting with regard to imaging, particularly the risks of contrast or the longer term impacts of radiation exposure? What do you think about that?
It's an interesting question. And of course, as a matter of law, it comes down to, again, this question from Montgomery, whether the risk is a material one. And in these sorts of circumstances, they often will be. For example, if radiation exposure has a known probability of a serious outcome, such as serious malignancy, secondary malignancy, even if that's a very low likelihood, it may qualify as a material risk and it might be reasonable to discuss that. Similarly, contrast allergy would be an example of a material risk of an intravenous injection of contrast.
Yes, and I think again, there's nuance to this because, of course, as part of your process of assessing whether it's safe for a patient to have a scan, they may well be asked about contrast allergies, and you'd have to explain the reason why you're asking those questions. And similarly, I think that the question of secondary malignancy particularly comes into focus when you've got certainly groups of patients I've dealt with abdominal surgeries in the past or inflammatory bowel disease having recurrent scans. Talking about that probably is more material and relevant to that patient group.
Yeah, similarly in my own practice, I'm thinking about children having lots of CT imaging, something that, of course, radiologists would try to avoid, but sometimes it being unavoidable, but being people thinking through the reason behind ordering the test and what the particular implications might be for that patient and that patient group more generally. And a lot of these discussions are, of course, are going to be intrinsic to the practice. You're just dealing with that, taking the patient through the procedures that they have. And of course, we're back to the point that when we're referring patients for these tests, we may start to be more explicit about our reasoning as to how they will benefit from the tests, why that's recommended, even if it involves a risk like radiation exposure. There were some other practical questions. For example, what would you do with a patient who refuses to listen to any of the detailed risks of an intervention, say a surgery? How would you approach that situation?
Now that's actually practically quite difficult, isn't it? And I can see that from the surgeon's perspective. But when we've taken advice line calls from doctors, I've also had that context from an oncologist where a person doesn't really want to know anything about their cancer and they're embarking on quite an involved and difficult kind of course of treatment. The GMC guidance does have some practical advice about that. I think it asks you first to consider what the minimum amount of information you have to share with that patient to make the treatment workable is, to allow them to participate sensibly in that course of treatment. For some complex treatments, it may be that you feel that this is impossible without their engagement. In others, explaining the basic plan, the basic risks, the things the patient should look out for and report to you may be sufficient. Needless to say, from a medico-legal perspective, you'd keep careful records of the fact that the information was offered. And of course, there's nothing to stop you giving the patient, written information to consider, um, and obviously leaving the door open to a further discussion if they wanted. Would you agree with that, Jared?
Yeah, no, I think it's important. These things, they don't have to be a one-off discussion. If somebody doesn't want to engage with you at a particular point, they may be upset about the diagnosis. They may need people around them to support them. You'd keep the door open for them for a discussion at a later point if that was something that was going to be possible.
Yeah, absolutely. And we know that a lot of our members will resolve these things in a kind of practical and empathic way, and we know that happens all the time. And of course, there will be some circumstances which are very, very difficult, but we know that you out there resolve these most of the time gradually in a sensible way.
We had a number of questions which, even when asked in quite specific terms, raised a lot of interesting general issues. The first one was about the usefulness of written information. I know we've kind of touched on that, but in particular with regard to the side effects of drugs or rare complications of procedures. What were your thoughts on that?
Yeah, again, I think the GMT guidance's focus now is very much on this issue of meaningful discussion, and they do sort of comment on things such as just a signature on the consent form being not enough on its own. But I think we've got to be careful at not sort of interpreting that as meaning that written information or written evidence of consent is not useful. I think it really is, and it complements the discussion that you have. So procedure leaflets, information from authoritative websites, videos, these sorts of things can all be useful. And we know that there are people out there doing a lot of work on how to engage patients in this way. And it can be a good way of communicating serious but rare risks that are probably not relevant to most patients. It may not hit that sort of, I know, slightly fuzzy threshold of what might amount to a material risk. For example, we had questions about the risk of death, even if it was minuscule. Must that be raised with every patient? Because most patients will regard it as being a serious risk, for example, in a routine general anaesthetic. And I think it's a difficult question to answer precisely for every situation. In that we appreciate a lot of patients may not take kindly to it being raised when the risk is minuscule. But equally, giving patients information about the safety of general anesthetics, but also making clear that there are very rare risks and quoting a risk of death in well patients and things like that, or setting out rare drug side effects from the common ones, that's hugely helpful. And I would say that written information is a very useful adjunct. I think it's still important that we give patients the opportunity to raise questions, to have that discussion, and always be clear in our correspondence how they can come back to us to talk to things. And of course, the written information alone may not be enough. If you've got a patient in front of you where you think the risk is not, more than just theoretical, and I know that's increasingly a case where, doctors are doing more and more invasive procedures on patients with multiple comorbidities who might benefit, but with death as a small but definite risk.
So I think in that context, what you're doing, you're giving people some written information, and allowing them to go through that in their own time, their own space with other important people in their lives, perhaps, and then coming back to you for further discussion, and you saying, was there anything in there that caught your eye, anything you want to discuss? Perhaps we can bring out some of the things that you're worrying about. And I think that would certainly be really helpful in terms of contributing to a meaningful dialogue as regards consent. Finally, we also had some questions that were what I'd say more of a sort of philosophical in nature, which was certainly very interesting. We had a lot of doctors asking about a circumstance when a patient wanted to go down a particular route of treatment, that a doctor didn't think was appropriate, or when a patient lacked capacity and their families or people close to them were demanding a particular treatment, again, that the medical team didn't think was appropriate. How would we approach that, do you think, Ed?
I think that is a really interesting question, and it's practically a very difficult and stressful problem when you face it in practice. Obviously, when you're dealing with a patient who lacks capacity, you have to reach a best interest decision in conjunction with their family. And if there's a very strong feeling in the medical team that the treatment is against the patient's interests, well, it's not something that you're generally able to provide. And similarly, with a patient who has capacity, although they give consent to taking risks, it again doesn't mean that you can provide that treatment if you fundamentally think it's professionally inappropriate to do so. We know from the case of Leslie Burke that doctors aren't obliged to provide treatment simply because a patient wants and consents to it.
Yeah, of course, that doesn't mean that there was a high risk procedure that would be appropriate providing the patient is willing to take the risk, that consent is not the relevant principle. I mean, of course it
Yeah,
is.
of course it is, and we know that doctors out there are doing high risk procedures where the patient could stand to get real benefit, but at significant risk, all the time, and that absolutely is reliant on consent and a frank discussion with your patients. In those situations when you're kind of caught in that middle ground where you can't reach an accommodation, where what the patient wants is not something you think is at all appropriate, you really need to look at that through the prism of how do you resolve that impasse, maybe by seeking a second opinion, giving time, trying to explore what's led to that impasse is really the more relevant question than that of just consent on its own.
Yeah, I think that's fair. We also had quite a lot of questions about how this fits into the high pressured, time pressured work environments that doctors find themselves in now. Whether new guidelines and these requirements for consent fit in with the realities of practice. I mean, how long do GPs get with patients now? 9 minutes is sometimes the average that we read about.
Yeah, I mean, I think that's got to be a concern to all of us. The GMC does recognise that this revision of the guidance is to some extent a direction of travel. So they want to encourage us to move towards this model of meaningful dialogue, etc., which a lot of doctors are obviously already doing. And they give some reassurance for what it's worth that their regulatory intervention is only really focused on persistent and serious breaches of that guidance. But I share that sense of discomfort that many of our members expressed during the webinar, that this is challenging. And I think that we have to kind of also see this, that this is not just an issue for doctors. It's an issue for all those kind of organising healthcare as well. And again, I'd emphasise that the discussions relevant to consent might not just be in that appointment. So all your contacts with a patient where you're giving and exchanging information, listening to their concerns, all of those things might be relevant to evidencing consent.
Yeah, I mean, it does pose quite a challenge, with keeping appropriately detailed records to capture all of those interactions to make it clear what has been shared with the patient. And of course, it's something that those who are organising healthcare will have to take account of.
No, I absolutely agree. I mean, I think this has got to be a challenge for healthcare as well as just individual practitioners.
Yeah.
We also had another interesting kind of philosophical question, really, about what about unanticipated complications, and these were a particular concern to our surgical members, given the well publicised issues relating to mesh implants. And perhaps the less well known but increasingly recognised lymphoma associated with breast implants.
That's a difficult one. Thanks for that. A doctor can obviously only engage with a consent-based discussion based on the state of medical knowledge at the time. And it's therefore going to be impossible, I guess, to consent for the unknowns. On the other hand, though, where we might not have full information about the long-term safety of treatment modality, it may be expected that you acknowledge that uncertainty in the discussion. I'm not suggesting that necessarily applies to these scenarios, but I think that's the only principle I can think of that helps guide us in these sorts of circumstances. Ed, thank you. Thanks very much for that. It's been a really helpful discussion to have with you. And that's it from us. And just to say thank you again for all your questions. We did have a lot of really interesting questions. We're sorry if we didn't manage to get to yours. We hope we've tackled some of the themes that were left that we couldn't fully address in the webinar. Please do check back on our website, www.themdu.com, for future webinars and events. They're being updated regularly, and we hope to be able to bring you more items of educational interest going forward. Thanks very much.
Yeah, thank you.